Hello everyone, hope all of you are doing well. This video demonstrates laparoscopic bilateral TAPP repair for a case of right-sided Amyand hernia and left-sided indirect inguinal hernia with a cord lipoma. So you can see after going inside, I saw that there is a irreducible component which was actually the appendix which went inside through the indirect defect, and it was stuck with the hernial sac. So you can see while I am pulling the appendix, it was not coming out and it is adhered with the hernial sac, and because of the periappendiceal inflammation, as you can see, appendix was quite inflamed and thickened, thick walled and a little bit edematous, but it is not perforated. So patient was having actually a few days history of pain over right inguinal region, and on USG it was not mentioned that it is a Amyand hernia or any gut related hernia. It was said that it is omentum, and there was no mention about the left sided inguinal hernia also. But when I went inside, there was a left sided groin hernia also, smaller than the right groin defect, and the right sided inguinal hernia is containing the appendix. So first thing, I was trying to reduce the tip of the appendix from all around the hernial sac, and after gentle manipulation and pressure compression from the outside also, I was able to reduce the appendix finally with a little bit of difficulty. My target was that during this manipulation the appendix should not perforate, because if it perforates then the field gets contaminated, and then my plan for hernia repair will be postponed. So luckily I was able to reduce the appendix without perforating it. So you can see how thick the appendix was, and there was additions, and finally I got to see the tip of the appendix, and now it is being reduced. So you can see the appendix is intact, the wall of the appendix is intact. It was going like this. So this was the first time I encountered a Amyand hernia, and finally, because there was no toxic fluid or there was no perforation, I decided to go ahead with the hernia repair. So I'll be starting with peritoneal flap creation for a routine right-sided TAPP repair. You can see I'm using a hook with monopolar cautery, starting from the median umbilical, right median umbilical fold, and staying at least 4 centimeter above the proximal border of the hernial defect. Just laterally giving the incision on the peritoneum, and I'm going into the preperitoneal plane, safeguarding the inferior epigastric vessels. We have to raise the flap like a routine flap, and laterally also you have to separate the preperitoneal fat from the dulux fat, so that you can get into the correct plane. Here you can see, so I'm keeping one layer of fat on the parietes, that is the dulux fat, and there is a layer of fat on the peritoneum, that is a preperitoneal fat. You have to go in between these two fat, and medially in between the layers of fascia transversalis we are creating. So you can see there is a nice layer of loose areolar tissue lying on the rectus muscle, the inferior epigastric vessels. So now going further, continuing with the peritoneal flap creation with a good amount of left hand traction is required. So you can see that left hand traction is main, because once you give good amount of traction you will be able to see the correct plane, and you have to, and then you can, with the monopolar hook, you can go on dissecting into the right plane and create the space of Bogros laterally and space of Regius medially. So here you can see, you just notice how I am putting my left hand instrument onto the peritoneal flap with controlled traction. Undue traction can tear the flap, but you have to be cautious enough that the traction should be good enough so that you can get to see the correct plane, and then you can go on dissecting onto that plane further. So here you can see. So going onto the indirect defect side, you can see the I'm dividing the tissues which are actually holding the peritoneal flap. Medially also I'm creating the space so that I stay in between the layers of fascia transversally, so that I get into the right space of radius, and the inferior epigastric vessels should lie over the roof of the area of the dissection that I'm dissecting. And here you can see, so very gentle traction, counter traction, and very minimal application of cautery. You should using the hook we can create and identify the correct plane. There is a glimpse of Cooper's ligament can be seen while I was dissecting. You can see the Cooper's ligament can be seen. So now I'm pulling the indirect sac with my left hand instrument and trying to separate the layers covering the sac and the cord structures. So idea is to separate the cord structures from the hernial sac, and as you keep separating, the idea is to make the sac isolated from the cord structures, and with very minimal application of energy sources. You should not directly apply energy on the cord structures, vast difference gonadal vessels. So good amount of traction with left hand instrument and gradually teasing of the cord structures onto the lateral aspect, so that I can completely dissect off the sac. So again, there will be some tissues which will be holding the sac from the medial aspect. I'm just trying to identify those fibers that I can divide so that I can mobilize the sac further. So indirect sac dissection is little bit difficult, so you need compression from outside. So your scrub nurse should press it from outside, and now you can see I am holding the extension of the iliopubic tract, which is known as loop of Schrodel, which should be divided. Otherwise you won't be able to do the paratylation completely. So now you can see I have isolated the cord structures and separated it from the sac. However, there is a small blood vessels which can be the cremasteric blood vessel, and cremasteric blood vessels can be divided nicely. So cremasteric blood vessel is there, which is actually adhered with the sac, so that can be divided in the process of dissection. As it was a large indirect inguinal hernia, so I have decided to divide the sac as distal as possible. And now you can see I am just dividing the sac and dividing it 360 degree, and then the division is complete, and the sac is separated from the cord structures. So then again the traction is very important. Now you are pulling the sac, and whatever the tissue fibers are lying in between the sac and the cord structures, that should be divided. So here you can see, so very gently traction, counter traction, and adequate space creation should be done. You can see the Cooper's ligament and the pubic arch now clearly. So with the back of my hook, I'm just applying a little bit of energy and pushing the cord structures away from the peritoneal reflection. Again, laterally, space of big Bogros should be created enough so that the lateral aspect of the mesh should be sitting nicely in this area, because inadequate lateral dissection often can be the cause of hernial recurrence. So dissection should be adequate so that the complete critical view of myopectoneal orifice can be achieved. All the hernial orifices can be seen nicely dissected. So now I am creating space of radius further. Here you can see the pubic bone, and I'll be going in between the pubic bone, the pubic arch and the bladder. But for that, before that, I'm separating the bladder flap from the rectus muscle, left sided rectus muscle. So now starting with the left sided TAPP dissection. So create first of all scoring the peritoneal incision point, and then creating the peritoneal flap, same as that I have created on the right side. So it should be an inverted J-shaped incision line starting from the left median umbilical fold, and then it will be going up to the left anterior superior iliac spine. And again, not just the peritoneum but the preperitoneal flap should be always be included in the peritoneal flap, so it becomes a thick flap. And medially again, you should be identifying the two layers of fascia transversalis. Here also you can see, like the right hand side, I am separating the dulux fat from the periperitoneal fat and keeping the dulux fat on the lateral abdominal wall so that it can protect the nerves overlying the psoas muscle. And again, medially I am trying to enter into the space of radius after creating the flap nicely, safeguarding the inferior epigastric vessel. It should remain on the roof. So just to give proper traction with the left hand instrument, you can see continuous changing of traction as I keep on dissecting. Your left hand should always progress along with your right hand instrument and give good amount of traction, counter traction, and sometimes blunt dissection like this, so that you can identify the correct plane of dissection. So left sided, from the right side I have already dissected a bit onto the left side. So little bit of, I'm trying to communicate the right sided dissection with the left sided dissection. Now you can see I am bringing the right handed hook from the right sided peritoneal defect, the peritoneal pocket, and dissecting it away, and left hand instrument is through the left peritoneal pocket, and then I'm using the right hook to create the space of radius, the dissecting and clearing all those areolar tissue so that the whole of the pubic arch can be seen nicely. And then the further lateral space creation is required. You can see, just trying to get into the correct plane here. Again, the left hand traction is proceeded with the right handed dissection, so that good amount of traction itself can create enough space so that you can go and create the correct plane. Again, the dissection is proceeded further. So now just trying to pull the hernial sac. There was an indirect inguinal hernia on the left sided also, so which was not mentioned in the USG report. And here, after going inside, I could see there was a hernia on the left side with a large cord lipoma, as you can see. So there was an indirect sac along with a large cord lipoma which should be dissected off. Now you can see I'll be pulling with my left hand instrument. So there is a large cord lipoma, and it is trying to get it separated from the rest of the cord structures. The vas deferens is already got separated, but and this is the vas deferens, but the gonadal vessels are actually adhered with the cord lipoma. So I'm trying to separate the cord lipoma from the gonadal vessels. Now you can see the gonadal vessels are getting separated. So you have tried to identify the correct plane, and until and unless you dissect the cord lipoma and the hernial sac along with the separate it from the cord structures, you won't be able to create enough space. You won't be able to achieve the critical view of my peritoneal orifice. You can see the iliopubic tract holding the cord structures from behind, and that should be divided to do the complete paratalization. So very gently with traction, counter traction, I'm trying to divide the loop of Schrodel. Here you can see. So this is the loop of Schrodel that I am dividing now, so that I can bring down the peritoneal flap nicely. So as I keep on dissecting on the medial aspect, external iliac vessel will come into the area of dissection, so it should be cautious enough. So undue energy application should not be done over there. It can bleed, and that bleed can be very torrential and difficult to control. So again, you can see the vast difference. I'm just separating the fibers of loop of Strodel from the vast difference, so that I can reflect the peritoneal fluid nicely, at least 5 centimeter from the defect margin area. Now you are getting to see the triangle of doom nicely. It is getting out. And medially also, as I keep on dissecting, I'm just trying to create at least 2 centimeter below the Cooper's ligament, so that nice space is created all around, and I can place the mesh nicely over that area without any undue folding. So I'm just checking how the appendix is doing. It's nice. So now you can see all the anatomical side: the triangle of doom, the external iliac vessels, the Cooper's ligament, the corona mortis, few vessels are there. There is the triangle of pain. There is the psoas muscle overlying nerve, which is covered by the dulux fat. Now the fatty layer, fiber fatty layer, that is the covering the psoas muscle, is the dulux fat, which is covering the nerves, and it should not be disturbed. This is the right indirect defect. This is the left sided defect. And now I'll be closing the peritoneal rent that is being created by me during the process of right indirect sac dissection. So I'll be putting a catgut loop, but before that I'm just checking how I should hold the whole thing, and then I can put the loop nicely in that area. See, here with my left hand instrument I'm holding the divided sac margin, and now I'm bringing the catgut loop, the true loop, that is same thing which is used for appendectomy. So now you can see I'm just tightening the loop at the neck of the just below the divided margin, and now it is divided, and just checking from below it is whether it is completely closed or not. You can see. So after that, mesh was kept inside. It was a 12 by 15 centimeter medium weight polypropylene mesh, flat sheet of mesh, medium weight polypropylene mesh. That is the this mesh is this particular mesh is supplied by the Healthium company, the Truline mesh, Truline Laparo mesh, 12 by 15 centimeter. So if the dissection area is adequate, and if you can unfold the mesh nicely, it will be sitting on the myopectineal orifice nicely without any undue folding. And if there is any fold, it means the mesh is not nicely tucked inside. So here you can see I'm just trying to tuck it more onto the lateral aspect nicely, and now you can see the mesh is sitting nicely without any undue fold. The lower inferior border of the mesh should lie nice and flat without any folding. Again, the right sided mesh was placed inside. In the midline there should be at least 2 centimeter overlap of the mesh, and mesh is nicely tucked again on the right side, so that all the hernial orifices, potential hernial orifices, can be covered nicely. Again, the lower inferior border of the mesh, placing it and tucking it nicely is of very important part of this mesh placement, so that After closure of the peritoneal flap, the lower border should not get folded, and that can cause hernial recurrence. So mesh placement, if the area of dissection is adequate, once you place the mesh, you will be able to place it nicely without any extra maneuver. And once you feel the meshes are nicely sitting over that area without any undue folding, for this, as fixation is not required. And for bilateral mesh, usually for unilateral hernia, I don't fix the mesh. If since this is a bilateral inguinal hernia repair, so I'll be fixing the mesh at one point only. So there is just single point fixation is good enough for this case. And now I'll be starting to close the peritoneal flap. So I'm first of all I'm using a 3-0 V lock. I'm closing the left peritoneal flap. Again, the peritoneal flap closure should be done nicely. So now the issue comes whether there is a debate in this kind of cases, where particularly in Amyand's hernia, where appendix was the content, whether I should do hernia repair and place a prosthetic mesh, because there was appendicitis, and there is can there be a infection of the mesh in the postoperative period. But since in this particular case there was no only appendicitis was there, but there was no appendicular perforation, there was no toxic fluid, and the patient's blood parameters are within a normal limit, there was no signs and symptoms of infection. The infection marker was within normal range. So I decided to go ahead with the hernia repair, keeping a good broad spectrum antibiotic coverage, prophylactic antibiotic, and then the postoperative 2 doses of IV antibiotic. And then next day this patient was discharged and was given broad spectrum oral antibiotic also, and the patient did well in the postoperative period, recovered nicely, and without any evidence of seroma or infection. So in selected cases where in spite of the content is appendix and little inflamed, you can do hernia repair with mesh placement, laparoscopic hernia repair, the same sitting along with the appendectomy. So here you can see I'm about to close the peritoneal flap, left sided peritoneal flap completely, and using the V-lock suture it becomes a little bit easier, because once you pull the suture it will stay like this, a self-locking suture, and the left sided flap is closed nicely. And before closing the right sided flap, just at the midpoint I'm keeping a fixation for taking both the meshes in a bite, you can see. So this is the proximal medial border of the mesh. So I'm fix it with the undersurface of the rectus abdominis muscle. So using the same suture, 3-0 V-lock suture. So after giving one bite and taking the needle through the loop of at the end of the suture, one more bite, and now dividing the suture, that is the fixation, that is a loose fixation, but it will, as since this is a barb suture, it will keep the meshes at that position. And now with the same suture I will be doing the peritoneal flap closure on the right side in a similar manner that I have done for the left sided peritoneal flap closure. So once it is the flap closure is done, the patient was extubated and shifted to recovery room and then to ward, and the patient was had an absolutely painless recovery, and patient did well in the postoperative period. The histopathology report of appendix came out to be benign, and it was only acute appendicitis. So appendectomy was done at the end of the flap closure, right-sided flap closure. It took me another 10 minutes time to do the appendectomy part. So the thing I did is, after reduction of the appendix, I checked the appendix and uh, and decided to proceed for the hernia repair. Completed the hernia repair, placed the mesh, close the peritoneal rent, and then I did the appendectomy. So as the suture tends to fell short, I took one more suture to close the remaining part of the peritoneal flap, and it came out nicely. And now I started doing the appendectomy using harmonic shears. So starting from the tip, I started dividing the mesoappendix and staying close to the body of the appendix, gradually going towards the base. So gradually I am going towards the base. You can see a long, thick walled edematous appendix, typical of acute appendicitis. So I'll be going till the base of the appendix, where the base of the appendix is getting broadened. Now you can see the mesh is nicely sitting on the right groin, and similarly the left groin mesh is also nicely sitting. The gas is already went outside, already deflated, because I kept needle on the scrotum, so that the extraperitoneal air is already gone. And now I'm keeping one loop at the base of the appendix and dividing it. Another loop I kept. So usually I keep two loops, at least 2 to 3 millimeter, 2 to 3 millimeter gap, and then divide the appendix just distal to the second loop. Took a specimen bag inside, kept the appendix in the specimen bag, and took it through the 10 millimeter supraumbilical port, keeping a. And after taking out the specimen, I just rub the divided margin with the betadine and place the omentum to cover the base of the appendix. Thank you so much.